And participants are now joining. And you can start.
Good afternoon. Welcome everyone. International Institute for afternoon, everyone. Welcome to the PHC webinar series that is organized by the International Institute for Primary Healthcare. International our focus would be on leadership and governance. So I would invite the moderator for our session today, Dr. Edward. Dr. Edward is a full-time faculty in the Department of International Health and a member of Center for Refugees and Disaster Studies and the Center for Global Health. She has extensive experience leading health systems and community-oriented research and evaluations for several organizations, including the WHO, DFID, PAHO, USAID funded quality assurance project 2, and MSH, Maternal and Child Survival Project of JPIGO, FHI 360, and NGOs like World Vision, World Relief Plan International, Future Generation, and Aga Khan Foundation in Africa, Asia, Latin America, and the fragile context in Afghanistan. She also teaches several courses on quality management and project development for PHC, and co-directs the Master of Public Health Leadership Management concentration. For over a decade, she studied primary healthcare course and supported projects and students with the interest in PHC. Welcome everyone again, and over to you, Dr. Edward, for the session.
Thank you very much, Dr. Antonin. It is a pleasure to join everybody. Good afternoon, everyone in Africa, and I guess good morning to those who are joining from the US. And welcome again to the PHC seminar on strengthening PHC systems in LMICs. Our topic today is leadership and governance in primary healthcare. I'd first like to thank Dr. Antonin Tirsit and the leadership at the International Institute of PHC Ethiopia for organizing this webinar on the critical topic on the role of leadership and governance in primary healthcare and the use of the evidence to how we can reconfigure healthcare systems and service delivery platforms. Over the past decade, there have been several global and national efforts to integrate new health system policies and reforms to build effective leadership and governance. USAID, through the Management Sciences of Health, launched the Leadership Development Program, and subsequently the USAID LMG project, which was Leadership, Management, and Governance, and subsequently the USAID Transform project with a consortium of partners. In Ethiopia, the Transform project has evidenced successful outcomes, and at the global level, the PHCPI initiative has shown evidence of successful policies and governance, especially in countries like Indonesia, Peru, and Malawi, ensuring effective stewardship and accountability at multiple levels. Today, I'm delighted to introduce a very distinguished panel of experts, each with decades of experience and strategic publications on primary healthcare. They will share evidence from their experiences, illustrating models from selected contexts And our objective today would be to look at how we have integrated leadership and governance in primary healthcare at the global level in Ethiopia and in Tanzania, and discuss the experiences we've had so far, and also have a facilitated panel discussion on challenges and strategies going forward. We encourage you to use the chat feature on the Zoom to post your observations and queries, which we can address during the Q&A session. If you would like to address a specific speaker, please direct your response to them on the chat. Our first speaker today is Professor William Brieger, and he is a public health education specialist with a doctorate in public health and international health from Hopkins University, and a master's in public health and health behavior and health education from the University of North Carolina in Chapel Hill. He is a professor in both health systems and social and behavioral intervention programs of the Department of International Health at Johns Hopkins Bloomberg School of Public Health, and also serves as JPIGO's senior malaria specialist. Dr. Brieger taught at the African Regional Health Education Center, which is now the Department of Health Promotion and Education at the University of Ibadan in Nigeria from 1976 to 2002. He is internationally renowned for his expertise in the social behavioral aspects of disease control and prevention, with special emphasis on formative research, primary healthcare, community systems development, and community participation. He also works on behavior change program design and evaluation. A particular focus of Bill Brieger has been the training of peer educators, community volunteers, and other community resource persons to take an active role in health education and health service delivery. He has served as a consultant in developing community participation, health education, and health system strengthening interventions with organizations like the US CDC, WHO, UNICEF, US Peace Corps, and various other USAID implementing partners. He has been a member of various scientific working groups and currently serves on the WHO African Regional Immunization Technical Advisory Group. He has pioneered online teaching since 1996 and delivers courses to and directs various graduate level programs at Johns Hopkins through the Coursera system. Dr. Brieger has published more than 175 scientific articles focusing on social and cultural aspects of disease control, health systems development, training of community health workers, community system strengthening, and community participation strategies. Over to you, Dr. Brieger.
Well, thank you for the very kind introduction. I've been asked by the group to provide a brief overview of the issues from a global perspective. I do have to say that my perspective has been influenced by the fact that when I was based at the University of Ibadan, together with our staff and graduate students in a rural community where we do training for medical, nursing, public health, and other students, we did start a pilot primary healthcare program in 1978, 77, 78. About the same time Alma-Ata started. So I've been fortunate to watch and see how Nigeria's system developed along the way. And of course, I've had particular interest in the governance and leadership aspects, because at the time we organized primary health care in the late 70s. Leadership in public health and primary health care was a big challenge. Communities were not as involved as they should be. And so hopefully things will have improved over time. I'm going to I've also added the word accountability into this because, again, you need to look back and see if the leadership and the governance are responsive to and responsible for the people they're expected to serve, and the communities have a say in what's going on. So again, over the years, several key meetings and documents have spelled out what should be considered as leadership, governance, and accountability. Simplify that as LG&A in primary healthcare. Most governments have assumed that these terms refer to their own formal activities in terms of legislating, in terms of setting standards and guidelines, both at the national and subnational levels, and in terms of administrative activities. But true leadership and governance and accountability for primary healthcare cannot be achieved without a prominent role of the community. A USAID document that looked at the governance issues in Rwanda, and we'll talk about Rwanda a bit more as an example, spelled out this framework for governance, and they clearly have citizens, clients, the community as a key part of the governance framework. So not just the policymakers that we're used to at various levels, not just the healthcare providers, but actual citizens becoming involved. So we cannot really address these issues without seeing how a country at all levels involves its citizens in primary healthcare. We can start, of course, things started before Alma-Ata. The idea of primary healthcare that we based our work on in 1977 at the University of Baden was through a faith-based NGO that was encouraging its members to have village health workers, to have outreach from their main mission hospitals. And what we found is that, you know, Alma-Ata definitely, you know, solidified many of the experiences that we had seen. So although the terms leadership and governance do not appear in the Alma-Ata Declaration per se, it does say that governments have responsibility for the health of their people, but this should be achieved by full community participation, maximum community participation in planning, organization, operation, and control of the primary healthcare process. So without that community component, you really do not have key leadership happening in primary healthcare. Something in the Alma-Ata that refers to governance is that government should formulate national policies, strategies, plans of action. And this should be done in coordination with other sectors. I think this was a unique aspect of Alma-Ata in that primary healthcare is not just health per se, it's all of national development. And in fact, now that we're looking at the Sustainable Development Goals, this issue of development, you know, there has to be an interaction with all development sectors in order to achieve health for all. And then finally, the issue of accountability can be seen in statements like the political will to mobilize the resources, use available resources rationally. So again, as Alma-Ata did not specify these terms, one can see that the concepts were clearly there. Everybody is familiar with, and I think one of our speakers will go into a little more detail about the building blocks concepts that WHO came up with in 2010. But again, building block 1 stresses coordination, networking at the local level across different types of providers, service delivery, routine, emergency, So this is something we need to pay attention to in terms of the leadership and governance. Coordination, as mentioned in that building block 1, it takes place not just within health, but across all kinds of sectors and all kinds of partners, and community organizations are clearly identified. And although, again, the word leadership was not explicitly used, you cannot have coordination without leadership. Then we come 40 years after Alma Ata in a meeting in Astana. And I think the capital, is now called Nur Sultan, but I don't think they've changed the name of the declaration. But again, this declaration does start to recognize the important words of leadership. The declaration was happy that governments have demonstrated strong leadership for primary health care, and that recognizing again that everyone needs to enjoy the highest attainable standard of health. And again, the declaration looks at stakeholders and at various types, various levels, various sectors, government, non-government, in terms of promoting transparency and participatory governance. Again, it's not a top-down approach, and we need to keep stressing that. The word accountability, fortunately, does appear, and it's part of the monitoring process, where a high-quality data are needed for countries, for programs, for communities to ensure that the health system is performing to meet people's needs. And again, accountability comes up a second time in that document, with reference to community ownership as a way of contributing to accountability, so that the people are not just recipients of care, but they're also participants in monitoring and evaluating what is happening with the system and bringing about improvements in the primary health care. One thing that document that it is often people are unaware of is from the Global Fund. You think of Global Fund as focusing on diseases, but it does focus on systems. It focuses on both health systems as well as community systems. There are documents that guide people in developing their Global Fund proposal that talks about the importance of strengthening community systems, various kinds of community organizations, community leadership, private sector, formal and informal, groups that exist in the community, ensuring that health programs are comprehensive but respond to the needs of particular communities, especially marginalized groups. The issue of equity is very important here. But again, you cannot have primary health care that meets the needs and is adapted to the realities of a local setting unless you have this community system strengthening. So without this, we run the risk of having, again, like I said, a top-down program, which is the antithesis of primary health care. So the community has a major role in accountability and advocacy, leading to better governance, leadership in both planning, delivery, and monitoring. What's actually happening in the countries? And it's an interesting contrast. On the left may not be as clear a picture from a report on what is happening in Nigeria and the way they conceptualize their primary healthcare program. At the top of the organogram, you have your state primary healthcare development agency, which is a parastatal organization affiliated with the Ministry of Health. Then you have your LG, the local government health authorities. Again, this is all government. And then finally, you have your health facilities within each government, your primary health facilities. It may be a maternity center, a dispensary, a health post, a full health center. But again, it's a health services, health facility approach versus Rwanda, where the emphasis is on having a minimum of 2 village health workers, a male and a female. They call them that pair a biome. And the idea is that these are people who live and work in the community, have basic skills, have basic supplies to address the needs. So there are in over close to 40,000 villages in, across the country, you have this system of the community being active in providing care. So we have a community approach or a facility approach. Both of these are called primary healthcare in their respective countries, but I want us to consider the implications of this in terms of the real accountability issues. So even though federal or national governments create offices for primary health care, these national offices governing over, millions of people actually reflect the local needs that should form the basis of primary health care. How accountable are these national offices? Even in state offices in Nigeria or provincial offices in other countries, we still have millions of people. Do the state or provincial ministries of health reflect the needs of the local communities? Governments take the lead often. They establish various kinds of management committees at the district or community level, but these committees are often seen as the purview of government, and there's very little community buy-in, community ownership, real community participation and decision making. So the funding processes may also be top-down, and this can come because of donor priorities. It could come because of national government priorities, but it's difficult to talk about primary health care where the needs of the locality come first. Rwanda, there have been many studies, and things are definitely not perfect in any particular country. But a couple of things that enhance accountability and governance in Rwanda is performance contracts at all levels, down to the individual community health worker. There are district planning processes that, again, are another accountability mechanism that involve community members. So they stress a real role for citizens in governance of the health system, including policymaking and service delivery. The emphasis on full participation that was enshrined in Alma-Ata is also part of this. And so you have what could be called co-governance, where the government that's actually elected by the people is also the primary health care program is managed together with government and community input. Nigeria has faced sub-national challenges. They were not able to date to really establish a primary health worker program that is based on community level people who are from the community, live in the community. They have frontline health workers. It sounds similar to Ethiopia, calling them community health extension workers. These people receive 2 or more years of training. They go back for continuing education. And they were ideally set up to run a health post, at the front line. Sometimes you find that they're actually doing more administrative, clerical, work under the guidance of a nurse or another member of staff. They really don't have the independence, the outreach into the community that was envisioned in the 1970s when the concept of community health extension worker was developed. So the subnational political will is found to be important. State and local government. There are 774 local governments. They all have responsibility constitutionally for primary health care, but the finance and the political will does not fall in those local subnational units as would be needed to enable them to involve their communities and particularly in decision-making, planning, and evaluation. So this challenge, affects leadership, management, financial, and technical support. That really the implementation of something as simple as having 2 village health workers per village in Rwanda has not been realized in any particular state in Nigeria. Just a recent note from the Commonwealth, the work that Kenya is trying to do to create primary health care networks that involve communities and health system was singled out as an important innovative step. So I'm glad we're going to hear about more examples, Tanzania and Ethiopia this morning, but there are governments trying different things. Like I said, some more facility and service based, some more community based. Again, the idea which model enables us to ensure full leadership, governance, and accountability down to the local level. How can we enhance community roles in these areas? So thank you very much, and I hope you enjoy the rest of the webinar.
Thanks very much, Professor Briga. That was a very fascinating overview of current leadership models and achievements and challenges that we need to consider when we have our Q&A session. I'm excited to see that we have about 212 participants ranging from PHC practitioners and healthcare providers, as well as university students, and we're looking forward to a very rich discussion. So Dr. Briga brought about several key important issues about the recognition of shared leadership, especially with engaging communities, the aspect of community governance, addressing the care continuum, coordination or multi-sectoral engagement, a wide array of actors being involved, a culture of shared accountability, how we create accountable care organizations right from the community right up to the policy level. He also highlighted the role of community governance, as well as the role of Global Fund in strengthening healthcare systems and especially community systems. We had a bit of an overview from Nigeria, what works, what failed, what still needs to be accomplished in terms of setting up leadership and accountability systems. Kenya's hub and spoke model seems to be working successfully. Are there aspects that we can benchmark? And of course, from Nigeria, we have examples of accountable care organizations. So how can we make community engagement authentic? And how can we make sure that healthcare is equitable, it's integrated, it's person-centered across the continuum of care, from promotion, prevention, treatment, to rehabilitation, and even palliative care? So think about the questions you would like to pose to Professor Briga but we are now moving on to our next speaker, and he has published extensively, and this is our second panelist, Professor McFarlane, NS, and for more than 10 years, he has served as a lecturer and researcher at the Department of Health Systems Management at Zumbi University in Tanzania. He teaches quantitative and qualitative research methodology and monitoring and evaluation. And he also teaches Introduction to Biostatistics, research methods in health systems management and public policy research and analysis. So those of you who are students who have logged on, this is the best place to get your degree and become primary healthcare experts. He's also a key facilitator in several short-term courses organized by the Center of Excellence in Health Monitoring and Evaluation, including M&E and Health Information Systems, including the DHI S2, FFARS, and HRHS, and TIS. His research interests include monitoring and evaluation, policy implementation and analysis, and reproductive and child health. He has authored more than 15 articles in internationally accredited journals, and he holds a diploma in clinical medicine from Mtwara Clinical Training Center, a bachelor's degree in public administration, health systems management from Mzumbe University, and he also holds a Master of Science in Population Studies from Groningen University in the Netherlands, and also a PhD in Demography, Family Planning, Program Implementation from the same university in Netherlands. He has been a senior lead and co-PI for several projects as the Data Use Partnership Project, a collaboration under the Capacity Building Consortium. He's provided technical assistance to the government of Tanzania and public health institutions towards sustained health systems strengthening in Tanzania under PEPFAR and supporting the government of Tanzania to strengthen leadership and management system. So over to you, Professor McFarlane. We are excited to host you this day.
Thank you very much for giving me the chance to share my experience in Tanzania, especially under this area of primary healthcare. As my colleague have already explained on starting that the primary healthcare is the cornerstone of the health systems, and for Tanzania, we can start the primary healthcare start from the lower level where we start with the different items and where the treatment of our citizens start. So in our case, as you already explained, have worked extensively in different aspects in health systems, but under this area of health leadership and governance have become an area of interest of recent, to make sure that if we strengthen the leadership and governance, it means we will have the clear and proper outcome in primary healthcare. And I will start my presentation by providing a simple explanation of what does the governance is mean and leadership it's mean, and then I will stress more on what we have done to improve governance and leadership in Tanzania. As you can see, the governance entails the values, policies, and institutions through socioeconomic and as well as political processes, where in order to make sure that all these are working properly so that we can govern the health facilities or health care in ending context, low middle-income country like Tanzania, we need also strong governance. And the governance is the way in which power and control are exercised among health stakeholders and over facility, and with the aim of providing the best services to the community. And we can find that in order to have the good governance, we have 9 principles that we should follow to make sure that it's being followed. And within these 9 principles, we can have a good governance in our area, which range from participation, transparent, accountability, rule of law, stewardship, responsiveness, health equity, efficacy, as well as ethics. And the next area we'll want to highlight is on the leadership. And the leadership is ability of influencing other or influencing behavior of other people or other workers, so that you can have much from them, and to realize your goals, and to realize to achieve the organizational goal. And this aspect, we need to improve the health service delivery. We need to make sure that we reach all people, and to provide the best health services. And in our country now, specifically to our Tanzania, the primary healthcare, it starts at a lower level, because our health system is pyramidal in nature, where we have primary healthcare, secondary healthcare, and tertiary. And at the primary healthcare, we have 3 levels, where we start with the dispensary, health center, and district level. And in each level, which means dispensary, health center, and district hospital, they are providing a certain services. For instance, at the district level, at health center, we only provide OPD services and some RSH services. But in a few cases, we have some dispensary which have the ward for the labor ward, where the women can have a delivery. But when you go to health center, it's more advanced with at least 20 beds, and we have some inpatient, but not few. But at the district level is where we have all specialization, starting from gynecology, obstetric, surgery, and the like. So with this presentation, we focus more on the primary healthcare in these 3 areas. And what we found after several analysis and several support supervision, we come to realize that in leadership and governance in our primary healthcare, there were some hindrances. And you find there are some clashes between the leaders, or those who were given power to lead these facilities. They were having clashes between themselves. But not only that, you find we have stockouts of drugs, we have stockouts of equipment, and there were some of the activities that were not well implemented. And when we go further by looking what was the clear issues, what was the problem associated with all these issues, or all this barrier, we come to realize that we have newly recruited staff who were not having the leadership and governance skills. And you can find that if this medical officer who is given the facility to be like medical officer in charge, or in charge of a certain department or units, they were not oriented on that. When you look on syllabus for the medical field, is mainly on treatment. The high dose is mainly on treatment, and less concentration on leadership and governance. So we see there are a need of impacting some knowledge on leadership and governance, so that this newly appointed, or this medical oriented staff, and being given the role of being manager, being leader, can have those kind of the skills, so that can produce and enhance the productivity of this area. Now we come to sit together with the President's Office, Regional Administrative and Local Government Minister in Tanzania, so that we see how we can impact his skills and knowledge, how we can reframe the guides, or the handbook, or the way of impacting skills, leadership and governance skills, without affecting the real situation or the way healthcare is working. And after a long discussion, we come to realize that the health system is being governed by the 6 WHO building block. Within this 6 WHO building block is where you can define the health system. And the health system has been revolving around this 6 WHO building block. And of recent, we have added the 7th, which is community participation or community involvement. But we say, okay, within these 6 WHO building block, but leadership and governance, it's cornerstone of all these building block, because when you have a good leadership and governance, you will ensure that the service delivery are well being planned and well delivered, because you will observe all issues related to governance, as I mentioned in the previous slide: accountability, transparency, ethics, rules of law. You will observe all those issues to make sure that you provide the services which confront to those dimensions. The same to health workforce. If we have a good leadership and governance, it means you can plan well on your health workforce in terms of rotation, in terms of knowing whether you have enough staff, or if you're dealing with some kind of rotation and whatever the case. The same to the health financing, the same to health information system, and the same to health commodity and technology. So after seeing if we have the good leadership and governance, we can manage all this, the other WHO building block. We come up with the guides, which is the practical guideline of what applying their book, and we write with basing on this WHO building block. We start with one WHO building block and zoom all issues related to leadership and governance and how can be addressed. We come up with the scenarios. With doing those scenarios, you can also have the clear picture, the certain scenario happening in a certain facility, and how as a leader or how as the manager you can address that. And within that, we managed to publish that book or guides in February this year, and you can find it online, and that is free access, so anyone can access. And within that, we have seen a lot of leaders who are managing this primary healthcare have used it and come up with their success and also their stories telling us that these have been of help. And we are thinking to continue to improve on such a way to have those practical guide that's really helpful to improve the leadership and governance. Thank you.
Thank you very much, Professor McFarlane. That was a fascinating overview highlighting the 9 principles of good governance, giving us an overview of Tanzania's 3-tiered healthcare system and the types of interventions that you've been instrumental in integrating. So we can see that leadership and governance plays a very pivotal role in optimizing the healthcare system and the functions. And we also thank you and your colleagues for the valuable contribution you made in designing this practical guideline that people can use and follow for optimizing primary healthcare leadership. You also highlighted some important considerations on how we should be considering the orientation of leadership. That's really important with managers as well to prevent clashes, and the barriers to good governance and leadership, and also giving us insight about current leadership practices and how it negatively impacts on staff motivation and patient care, and that the healthcare context underpins poor leadership, especially participatory leadership. So I would like to encourage our participants to think about the barriers for participatory leadership. What are the resource shortages? What is the organizational culture we should create for centralized decision-making or individual decision-making, and preventing medical professions dominance, which occurs very frequently? How can we disrupt the status quo of current leadership practices that have negative consequences? So we will now move ahead to our final panelist, who has incredible experience working on leadership management and governance project. Mr. Temigisin Ahiu is the Primary Healthcare Director for AMREF Health Africa in Ethiopia. He has a Master of Public Health in Health Systems Policy and Management. He is currently working for AMREF as a Primary Healthcare Director. He also worked for the Ministry of Health in Ethiopia as the PHC Director and for John Snow International as Leadership Management and Governance Officer. He has been actively engaged in the design and implementation of different primary healthcare and community healthcare programs and initiatives in Ethiopia for over 12 years. So welcome, Mr. Ahiu, and we are looking forward to your insights on leadership and experience.
Thank you very much, Dr. Amresi. So thank you for the introduction. And I'll try to highlight, especially the what leadership and governance is, especially in the from the WHO health system building block and the key functions of leadership and governance. And later on, I'll also focus on what are the experience of Ethiopia in these key functions of leadership and governance pertinent to the primary health care. So this would be the outline of my presentation. As I've said earlier, I'll try to use the WHO's definition on what leadership and governance is and what are the functions of leadership and governance. In using that definition and also the functions of leadership and governance, I will try to highlight the major initiatives and programs that are being implemented in Ethiopia when it comes to leadership and governance. So as previously said, the World Health Organization came up with a framework to especially to help us understand what the health system is, using the health system building blocks, and it tried to define what is the health system building block is. So according to this definition, there are 6 building blocks, which includes the service delivery, that includes the type of services that should be provided and how these services should be provided. That's especially focusing on the service delivery modalities and also focusing on the health workforce need in terms of number, mix, and also ratio targeting the population, and also what type of the health information systems that we need to govern and also lead the health system, and also the required medical products, vaccines, and technologies to deliver the health services, and also the critical component financing, which includes revenue collection and risk pooling, and also purchasing of health services. And finally, the focus of our topic, leadership and governance, which actually relates to other building blocks of the system. And WHO tried to define what leadership and governance encompass. And like for our presentation today also, we use this definition. And leadership and governance, it actually involves to ensure the strategic frameworks exist and they are actually combined with effective oversight and intelligence, and also building coalition among other sectors and also external stakeholders, and also the provision of appropriate and fair regulations and incentives, and also giving due attention to system design and accountability. So when we see the key components of each functions, like for example, the first one is to provide policy guidance. When we say policy guidance, actually it means formulating primary healthcare related strategies and policies, and actually designing specific technical policies to achieve primary healthcare in a country. And when we say the intelligence and also oversight, it means ensuring the generation, analysis, and use of data on trends and gaps in primary healthcare and health outcomes. So it includes analyzing the data in regards to inputs and also availability of primary healthcare services, and also the outcomes expected to achieve. And the collaboration and coalition building, it includes actually creating a collaboration across different sectors in a government, and also with actors outside the government. That includes civic society organizations, and with a primary focus of addressing the determinants of health and access to health services. And also, this is also one of the functions of primary health care. And the other one is the system design, which is mainly focusing on ensuring a fit between the strategies that we have and also the structures that we are building to provide primary health care. And the fifth function of primary health care is also regulation. This includes designing regulatory system and also incentives and ensuring they are fairly enforced, especially among public and private providers. And the last one, and also the most important one, is accountability. And Prof also tried to highlight this one. This includes ensuring all health system actors are held accountability. And this also includes social accountability platforms or mechanisms or communities can actively engage. And we'll also see an example from Ethiopia on this aspect. So before going to each leadership and governance functions and what are the main strategic initiatives or programs being implemented in Ethiopia, I'll try to highlight how the primary health care service in Ethiopia is governed or structured. So we can see like in 3 areas. The first one is how the administrative structure is governed, and how the primary health care service is structured, and lastly how the community structure looks like. So when we see the administrative structure, so Ethiopia is a federal government, and there is a federal government, regional government, and in some regions there is a zonal structure, but in all regions there is a warada or district structure, which is actually the most important structure when it comes to the primary health care service provision. So at national level, we do have a Ministry of Health, and in that Ministry of Health there is actually a health extension program in primary health care directorate, which actually leads and coordinates the primary health care activity at the national level. And similarly, at the regional level, there is a similar unit of directorate. The name may be different in some regions, but the functions are similar. And in some regions, especially bigger regions, we do have a zonal health departments. These are actually extensions of the regional health bureaus, and they support the regions in supporting the order health offices. And the district health offices, they do have actually an average of maybe 100,000 population, and they are the one actually leading and coordinating the primary health care units at the district level. And when we see the primary health care service provision, in the rural areas, we do have health centers with an average population of 40,000, and they provide primary health care services to these people. And in rural areas, we do have actual health posts, health centers, and primary hospitals. And the health posts are where health extension workers are stationed with this estimated number of population. And health centers and health posts actually function as a primary health care unit, and they provide primary health care service for a population of 25,000 people. At the community level, like beyond the household, we do have 1-5 networks in some areas actually. These community level structures and the community engagement modalities are being currently refined and revised. And we do have also a community based health development teams with a population group of 30 households that work in collaboration with the health extension. So this is how the governance structure of primary health care looks like in Ethiopia. And when we see the key functions, actually I tried to highlight majority of the functions. So the Ministry of Health is mostly responsible for developing national policies and guidelines, and also to provide a policy and technical guidance and coordination of actually the donor support at the national level. And there are also selected specialized hospitals which are governed by the Ministry of Health. Similarly, the regional health bureaus, they coordinate and execute all activities in the health sector within their respective region, and mostly they contextualize the national guidelines for implementation at the regional level. And when it comes to funding, they may receive funding from the Ministry of Health, like fundings like the Global Fund and something that came from the Ministry of Health, and they also get funding from their regional government, which is actually endorsed by the regional council. And these regions, they mostly coordinate general and primary hospitals at the regional level. And when we see the Warada level, mostly they are accountable to the Warada administration, and there is also an elected Warada council. This is a district, similar to a district, and the district health officers mostly have a technical link with the regional health bureau or general health department, and they oversee and coordinate the primary health care units within that level. So when we see the major activities being implemented in Ethiopia, like in each or selected leadership and governance functions. So the first one, like the first and the second one, is primary health care policy guidance and oversight. In terms of policy, now Ethiopia is revising the Ethiopian health policy. The previous health policy was actually enacted during the transitional government, and primary health care is still a priority in the previous policy and also in the current policy, which is almost actually submitted to the Council of Ministers. So in the policy document, primary health care is still a priority. And the other essential policy document that prioritizes primary health care is the essential health service package, which was revised in 2019. And this policy document prioritizes a total of 1,018 interventions that should be provided to the people of Ethiopia. And when we see in this, when we see these services, nearly 60% of the interventions are expected to be delivered through primary health care. And the other most important document is the health sector transformation plan. Previously, it used to be called the health sector development plan. This is a strategic plan for the health sector, and mostly it's a 5-year. And this guides the overall health sector implementation in a country for 5 years. And currently, the existing strategic plan is the health sector transformation plan, which runs from 2020 to 2025. This document also highlights the commitment of the government to achieving universal health coverage through primary health care. Currently, actually, the government is trying to revise this health sector transformation plan to align with its midterm expenditure framework, and it's under development. It's called the Health Midterm Investment and Development Plan. In that plan, also primary health care is a priority. And also, when we see the planning process in Ethiopia, so based on the 5-year strategic plan, an annual plan is developed through a district-based health sector planning. So it follows both a top-down and bottom-up approach, where the Ministry of Health prioritizes core or priority plans as a nation, but that will be cascaded to a district level, where the district contextualizes its plan and develops a comprehensive plan, and that will be later aggregated to a national plan. So there is a core or indicative plan at the national level, and using that indicative plan, districts they develop their annual plan, which is aligned with the health sector development plan. And the other key strategic or policy guidance or documents include, for example, the health extension program is one of the platforms where primary health care service is being provided. So there is a roadmap for optimizing the Ethiopian health extension program, which is actually a 15-year roadmap that guides the implementation of health extension program over 15 years, like separated in 5-year strategic plans. And the other policy documents that will guide the primary health care implementation in Ethiopia is primary health care strategic framework. This is a document which is under development by the Ministry of Health in collaboration with partners. And this document is actually aligned with the recently released WHO and UNICEF document about the operational framework for primary health care. So this document is more comprehensive and will provide a comprehensive guidance for primary health care service in provision in Ethiopia. When we see the structure, actually currently the community engagement and primary health care directorate at Ministry of Health, and also it's similar units at the regional health bureau, provide the coordination, monitoring, integration, and implementation of national primary health care strategies and policies. So the second function of governance is collaboration and coalition building. So in Ethiopia, the Ministry of Health has a health harmonization manual, which actually helps to govern the health sector. So in that manual, there is the health sector governance architecture platforms. This platform includes the Joint Consultative Forum, the Joint Steering Committee, and also other platforms. These are the major two platforms. So this is actually the Joint Consultative Forum. The members include Ministry of Health and major health partners, especially donors in Ethiopia, including the UN agencies, PMGF, and also the USAID and other donors. So this is the highest governing body of health in Ethiopia, and it guides actually the implementation of PHC policies and strategies. And the other platform is the Joint Steering Committee. So as I said previously, Ethiopia is a federal government. So there is a federal government, and also there are regions which are actually autonomous. So to create a linkage between this and steer the primary health care governance, there is a Joint Steering Committee. And this Joint Steering Committee actually meets every 2 months. It sometimes may not happen every 2 months, but it's expected to review the performance of the primary health care and decide relevant policy issues on primary health care. And also regarding the linkage between other sectors, there are specific multi-sectoral committees or bodies, like for example, for nutrition, for hygiene and sanitation, for HIV and so on. But in the health sector transformation plan, the multi-sectoral coordination, and also in the strategic framework for primary health care, multi-sectoral coordination is listed as one of the implementation arrangements for primary health care. And recently, there's also a health in all policy guidelines that's under development. This also will provide or improve the multi-sectoral collaboration, mainly to address the social determinants of it. And the other leadership or the other governance functions that I want to highlight is accountability. And some of the accountability frameworks or mechanisms that are being implemented in Ethiopia include the community scorecard, which is a social accountability framework. And also recently, we are also working with the Ministry of Health to test and scale up a managerial accountability for primary health care, and also health facility governance boards are some of the accountability frameworks with the aim of improving access, quality, and accountability. Like so, hospitals and health centers are expected to be governed by governing boards where community members are represented. And these governing boards provide strategic planning, approval of budgets, and facility performance management. Actually, this governing body may not be functional in all health facilities, but it's functional in majority of hospitals and health centers. And similarly, at the community level or at the health post level, there are also village health committees where health extension workers and community representatives are engaging. So the evidence shows that, like in a facility where there is a well-functioning governing body, there is an improved hospital performance in terms of quality and finance. So this is some of the bottom-up accountability frameworks. There are also top-down performance accountability tools that are being introduced. This includes the district management standard with the aim of measuring the management capacity and performance of the Warada or district health office. And similarly, health centers and hospitals also, they also implement these reform implementation guidelines, which have different chapters, but which help to measure and also improve performance management systems at the hospital and health centers. So just to give a brief highlight about the community scorecard. So as you can see, at the community level, health extension workers or the health development army members and also selected community members will conduct a scoring of health facilities using 6 indicators that help to assess health centers and primary hospitals on the service provision. These indicators include ambulance availability, waiting time, and also how the health workers are compassionate and respectful, availability of medicines, and so on. So there are recurrent councils at the village level who will facilitate this community scorecard on a quarterly basis. So after scoring, the result will be presented to the health center and or the primary hospital, and the health center or primary hospital will develop an action plan to improve their performance. And actually, in some health centers, I can't say all health centers are conducting this one, but in some health centers, there's also a town hall meeting where community representatives and also the district health office representatives will gather and will review the community feedback that came through the community scorecard, develop action plan, and monitor the performance of the health centers or primary hospitals in managing or in responding to the community feedback. So through this cycle, it helps us to improve the responsiveness of health facilities and also to create accountability in the health center. So I think currently more than 600, I think, districts are implementing this community scorecard approach, though there are some limitations in some districts. So just to highlight the community scorecard approach in Ethiopia, just there will be different challenges when you go to in different regions or in different districts, but to highlight some of the challenges when it comes to leadership and governance in primary healthcare in Ethiopia. One is a low representation of women in primary healthcare leadership roles. So, like for example, if you see majority of primary healthcare workers, including at the health center level, even at the health extension workers, there is a significant number of women health workers working as a primary healthcare worker. But if you see the leadership positions at health centers and district health offices, mostly it's dominated by male health workers. So there is a low representation in this regard. And also when you see the planning process, there may be different implementing partners working in a district. So unless you do a proper resource mapping, it will be difficult to harmonize resource mapping and create the stewardship that's needed. So this is also one of the challenges. And there is also actually a high turnover of health leaders, especially at the district and the facility level, which requires retraining of these health workers. And when we see the community scorecard, the representation of the different community groups in this community scorecard may not be adequate. And as actually the civic society organizations engagement also is low. And when we see the implementation of national level policies and strategies, so it lacks some contextualization to different regions or contexts. Like we do have urban districts like Addis Ababa or urban like cities like Addis Ababa and Redwa, and we do have a pastoralist regions like Afar and Somali, and agrarian regions like Oromia or Amara. So these national policies, strategies, and guidelines, they need contextualization. Actually, currently there is a lot of contextualization happening, but it still requires more work. And there is also actually a gap in primary healthcare leadership capacity, mostly at the facility or at sub-regional levels, which requires further attention. So this is some of the issues that I want to try to cover in this presentation, but hopefully I will try to address some of the questions during the question and answer session. Thank you very much. Over to you.
Thanks very much, Mr. Ihu. This is definitely a very fascinating overview of both Ethiopia and Tanzania and the current innovations that you have integrated. So Mr. Ihu provided the key functions of leadership and governance and the policy oversight at various levels. How to lead from the bottom, setting up leadership frameworks from the national and driving it down to the warda level. He also spoke a lot about how you leverage strategic investments from the guidelines and policies, collaborating and coalition, providing us a roadmap, and more importantly, coming to how you lead from the bottom up using social accountability mechanisms and using citizen scorecards, community scorecards, but also to talk a little bit about the Transform project, which enhances competencies and making sure that there's on-the-job mentoring and support, ensuring that there's performance enhanced through the work environment, and eventually creating responsive health systems with improved allocation. So team-based and experimental learning, open discussion to share experiences, and on-site coaching that happens with the community scorecards. So it seems like, as Albert Einstein said, if we were given 1 hour to save the planet, he would spend 59 minutes defining the problem and 1 minute resolving it. So all our panelists have described the problems, some innovative approaches, and also highlighted challenges, especially in terms of how you operationalize and optimize the community scorecard to assure gender balance and engagement of civil society organizations. So now we are going to move into the Q&A session, though we have only about 15 minutes. We would like for you to, if you haven't posted already, maybe our panelists can pick questions from the chat. If not, I will post some of these questions directly to you, and you can respond to them. So I'm going to go from the last speaker, Tennis again. In terms of the challenges that you described with ensuring community governance with community scorecards and other social accountability mechanisms, what suggestions, ideas do you have to address the challenge, ensuring equal or female representation in the leadership, engagement of civil society organizations?
May I proceed?
Sure.
Yeah, thank you very much. So I think in order to have more female leaders in the primary health care, I think one thing is to create an enabling environment for female health workers to engage in leadership competency trainings and opportunities, and maybe mentorship opportunities for female, so they can get the opportunity to build their capacity in terms of leadership, governance, and also management competencies. And the other thing is, I think it's good to identify and address what are the barriers that inhibit women health workers to take the leadership positions. So there are actually some experiences that you also highlighted, including the USA Transform Primary Health Care Project, where a tailored leadership management course, leadership management and governance course was provided to female health workers, so they can, so it can enable them to promote to leadership positions. Similarly, the International Institute for Primary Health Care also is implementing a leadership incubation program where there is an intentional representation of women participants in these training courses, so that can enable them to or that will improve their competence in terms of leadership and governance. So this is some of the criteria, but there can also be other mechanisms where the government can create, for example, a ratio or something mechanism where this percent of women leadership, for example, in a district health office management or health leadership management can be female participant. For example, when we see the health facility governance boards, at least there must be one female representative in this governing board. So this type of legislations also will help to create that type of opportunity. Regarding the engagement of civic society organizations in the community scorecards, so there are actually an ongoing initiatives that is being supported by local, like implementing partners, but also with the Ministry of Health, where the community scorecard is being facilitated or supported through a community or local level civic society organizations, where this can be mainly more in terms of independence, that will create independence and also trust from the community, and also they can also raise the voice of the people to the local leadership and also the regional and federal governments as well. Just to also address some of the issues that was highlighted also in the question, the Q&A. like regarding the challenge of the community scorecard. I think one participant also asked regarding the political commitment in terms of community scorecard. So I think that's also one of the challenges. So if you see, like in some districts, the communities, they gather every quarter, they assess the health facilities on selected indicators, but responsiveness of the health facilities may not be adequate enough to the community needs. So this actually goes back to also a political commitment, but also other factors. So definitely there is also a challenge in that aspect. But I think recently the ministry is planning to scale up the community scorecard approach with some modifications. So it will be scaled up to other districts very soon, hopefully. Thank you.
Thank you very much. I think there's one more query in the chat, and maybe you can respond to Zenebi directly about how the community scorecard considers the new structure of VHL. Maybe you can post that directly in the interest of time. And may I request all the panelists to turn your video on so distinguished audience can directly interact with you and see who you are. My next question is directed to Professor McFarlane. You mentioned that there's no orientation on leadership and some of the barriers to good leadership and governance, the clashes between leadership and managers, and how we change the status quo of the current leadership, which sometimes negatively impacts staff motivation. So if you could respond to that question while I pick up another question from our chat. If you could turn your video on, that would be wonderful. Thank you.
Okay. Thank you very much for the nice question. As I explained in my presentation, that some of these clashes between different organs or different leaders or different, for example, health facility in charge, maybe with village leaders or council, etc., are happening because of lack of knowing leadership and governance. Because when this leader are being oriented on leadership and governance, they will know that even though they are governing a certain facility or they are leading a certain facility, there are other governance structure which also interact with them, and they have day-to-day kind of working relationship. So if all this, they'll be capacitated on issue related to leadership and governance, and know all governance structures that is being around him or her, I'm assured that all these clashes will be not be there. Because sometimes you find this kind of clashes is being contributed with those we can say like professional arrogance, being say that I am maybe a doctor, I am a nurse, I am this kind of profession, or I'm a leader of this village, so I have all this power. But if all these people know that their roles, the principle of governance, the leadership, and they know what is connect all these people, I'm sure these clashes will be minimized, if not eliminated.
Thanks very much, Professor, and we're all looking forward to reading your book, the manual, and there have been many requests on the chat, and I think they all now have a link. So we will, there are, I think, about 18 questions in the Q&A tab. So before we move on to that, I have one specific question for Professor Brieger, and then we can take a couple of questions from the 18 that are put in the Q&A tab. So Professor Brieger, you talked about the strategy being skewed toward donor interests, and also the issue of subnational political will and financing for primary healthcare. These are big issues. So in your experience and in your thinking, how do you think we can overcome some of these barriers? And you can pick any one of those.
Well, the donor issue is a big challenge. I was briefly in another webinar before this one started. There are several things, of course, always going on at the same time. But the issue of national health accounts, who pays for things, the idea in some countries, majority of health expenditure is out of pocket. The consumer pays for it. Always present a challenge. And sometimes we see that the amount of donor input is relatively small. I think in Nigeria, about 2/3 of expenditure is by people themselves out of pocket, whereas only 10% comes from donors. And so, clearly donors, have some sway, but ultimately it's the consumer who goes to the private sector, the public sector, the NGO, the faith-based sector to get their health care. And sometimes what donors do is irrelevant. But in other countries, the national health account, a majority of the money is coming from donors, and there's thus a huge dependency. So if the donors are not buying into national primary health care policies, if they have made commitments to their own legislatures and Congresses about what they will do, will focus on HIV/AIDS, whereas the needs in the country may be nutrition, or they may be non-communicable diseases increasing. So there has to be some level of coordination and holding people responsible by the countries themselves. I mean, sometimes the countries, don't want to look what the saying, look a gift horse in the mouth. They don't want to question the donor. They just want the money. But what that does is make policy making very difficult. So the key issue there is that countries have to take charge of their health, and they also, as was mentioned, have to give up some of this professional pride and have an attitude of service, such that not only are they trying to coordinate the donors, but they're trying to listen to their people such that the donors are responding to that. So it's a bit complicated, but again, it's all in the hands of donors. And I've heard in various seminars and whatever over recent years that, oh, we shouldn't take money from any donor. The countries should do their own thing so that they are meeting their own needs and not being dependent. In this world, of course, interdependency is impossible to avoid, partly because the problems are not just created in one place, as we've seen in climate change. But I think, again, unless countries take charge and coordinate the various inputs, it's not going to be easy. Just a question to y'all. I have tried to respond to a number of the items raised in the Q&A, and I'm not sure what happens after I type that in and who can see it and where it goes, but I know I've responded to about 10 different items there. So hopefully somebody is seeing that.
Yes, that's the Q&A questions are being collated, and we are going to pick a select few. So Bill, I'm going to start with you.
No, but I meant I've already typed in the answer. So what happened to all of that? I don't want to have to repeat myself.
Sure. I will ask the leadership at IPHC if they have responded to it. So it's on leadership. I don't know if you responded to the leadership is a cause. All others are an effect is the prevailing notion. Leadership is also practical. How can leadership be taught to managers so that they lead and not just manage? Can leadership be taught as merely a subject to affect the need for change? And as you're responding to that, I'm going to address another question to maybe Professor McFarlane on the sustainability of the services and achievements, which may be disrupted because of limited resources. How do we ensure sustainability? And the third question is directed to Mr. Ehihu how do we as implementing partners work with policymakers to garner support that will ensure all peoples respect their roles and put their best to make the framework effective. We have about 4 minutes, so I'm going to give each of you 1 minute to address those questions that were posted. Starting with you, Bill.
Okay. Yeah, Koku's question came in just recently after I'd already answered a lot of the others. But yeah, leadership in theory can be taught. In practice, it needs practice. I mean, the thing is that we've done a lot with in-service training to try to have like management of local government or district health staff work together with community leaders so that they develop a process of collaboration. So a hands-on approach is necessary. I mean, the idea of basic training, whether it's doctors, nurses, as some of the other speakers mentioned, there's a lot of attitudes that are imparted with not mentioned in the curriculum that lead to some of these concerns about, you know, people in the health system thinking they are better than the people they serve. And so somehow we have to look at our hearts, look at our attitudes, and see what our training is doing to encourage a partnership approach by health workers, not some, you know, not that they know best.
Thanks very much, Professor Brieger. Over to you, Professor McFarlane, the question on sustainability.
Oh, okay, thank you very much for the nice question. Yeah, I read this question on sustainability, and my stand is that there are some of activities that we are doing which may be a bit difficult to be sustainable, but the good way of making this to be sustainable also is to be incorporated in normal function of that country, or normal way of implementing a certain activity. And whenever we start in any activity, we should also to assimilate it in the health system of that area or that country. For instance, we may be having a number of activities or the program or intervention which is donor driven, and the one thing we need to make sure that we integrate, whenever we do that, we should make sure that it's being integrated to those health system of that country. And for instance, in our country, in Tanzania, currently what we are doing, many of activity that's being initiated should also be paved a way to be included in planning and budgeting of the facility and council, etc., so that at the end, when this funding, if it is outside from the government funding, is being waived out, it can be sustainable and being continue to be implemented.
Thanks very much, Professor McFarlane. And though we've come to 9:30, maybe Mr. Ahil, you can address the question on implementing partners to garner support, and we will wind up after that question.
Yeah, I think implementing partners can work closely with government, but also with health workers and communities to identify the communities and also issues raised by health workers, so that this can be reflected in the government policies and priorities, and also to make sure that they are adequately financed, and also to support the Ministry of Health, regional governments, and the local governments also to support them in prioritization of interventions, and also to allocate the essential investments to the right investments, so the right interventions and needs of the communities. So there are different platforms where the local implementing partners engage, like the technical working groups, and also there are also other platforms when we can support the government in strengthening the primary health care and to mobilize additional funding and to make sure that that funding is efficiently used to the appropriate interventions. Thank you.
Thank you very much, Mr. Yu. I want to thank all the panelists and our very captive audience who have posted very interesting observations and questions. We've heard a lot about different case studies from Rwanda, from Tanzania, Ethiopia, Nigeria, and we've got some tools and equipped with some frameworks and manuals for us to lead effectively and govern effectively. But it seems that we still have to address some of the remaining challenges, the most important being the financing for addressing leadership and governance at all levels, the authentic and full participation and engagement of stakeholders. So there's a shared leadership and looking at how we can move forward with what we are equipped with in terms of driving leadership and governance from the national to the subnational levels and even to the community levels. So I will now turn it over to our organizers. But before that, let's give a hand to all our panelists who've done such an incredible job of decades of leading change and governing change in the most difficult and complex context. So let's give a hand to our panelists, and I will turn this over to our organizers as we are a few minutes over time. Thank you very much.
Thank you so much, Dr. Edward, and all the panelists for a nice session, and also for the participants for a very active participation and engagement with all 90 minutes of the session. So thank you again. So we'll be sending the recording and the resources shared by the panelists, and we'll be having the institute in collaboration with Johns Hopkins. We'll be having some course and webinars upcoming in few days. So please stay tuned, and we'll be sharing the links for registration and for the course promotion materials. So stay tuned. Thank you everyone for your time and for joining us. Have a good evening. Have a good day.